Hello and welcome, fellow student doctors. Today, we will discuss neurodevelopment with a focus on neurotube defects, which are the most common congenital defects of the central nervous system. As we will see, neurotube defects, once they occur, can result in death, paralysis, loss of motor and sensory functions, and incontinence, even if they are surgically treated. Therefore, we need to focus on prevention, as we should with all of medicine. Largely, neurotube defects can be prevented with folate, vitamin B9, supplementation. Friends, keep this quote from Benjamin Franklin close to your hearts and minds. An ounce of prevention is worth a pound of cure. Join me in this presentation as I get you ready for the boards and the wards. Let's get started. To prepare you for test day, you will be able to 1. Understand normal neurodevelopment. 2. List causes of neurotube defects. 3. Explain the importance and role of folate in neurotube defects. 4. Explain disruptions to the rostral and caudal neurotubes. And 5. List derivatives of neurocrest cells. Pictured here is a cross-section showing the development of the embryonic germ layers. The ectoderm is pictured in blue, and it gives rise to the nervous system and outer appearing structures, like the skin and hair. I call the ectoderm the attractoderm, since we are attracted to others' appearances, like their skin and hair and their intelligence, all of which comes from the ectoderm. The mesoderm is pictured in light red, and it gives rise to the bones, muscles, and circulatory system, so I call it the mesoderm, as it provides the means of moving around and moving things around the body, hence the circulatory system. Pictured in yellow is the endoderm, which gives rise to the digestive system and budding structures like the respiratory system, liver, pancreas, and more. I call the endoderm the internal derm, as these structures are internal. With that background, let's talk about neurodevelopment specifically from the ectoderm. The notochord, a mesoderm structure as its light red color suggests, begins to produce a protein with the coolest name ever, the Sonic the Hedgehog protein, to induce the overlying ectoderm to become neuroectoderm. At the same time, cells surrounding the developing neural plate begin to express bone morphogenic protein, which belongs to the TGF-beta family of signaling molecules. The dual actions of these proteins on the overlying ectoderm induce it to become neuroectoderm and begin to fold inward. Eventually, through the signaling of these proteins and other proteins, the neural folds continue to invaginate and close to form the neurotube. The neurotube goes on to form structures of the central nervous system. Notably, it's called a neurotube as the tube is hollow and, as you may suspect, the hollow space goes on to form the ventricles of the brain and the central canal of the spinal cord, which develop around the opening in the tube. Pretty cool, huh? These cells represent the neurocrest cells, which go on to form the structures of the peripheral nervous system. They are called neurocrest cells because as the neural folds form the tube crests at the top and these cells are formed. We'll talk more about neurocrest cells later. It turns out that neurodevelopment undergoes a process called patterning, where the dorsal and ventral aspects of the neurotube, separated here by a yellow line, are patterned into specific structures. Let me explain. The basal or ventral aspect of the neurotube, called the basal or ventral motor plate, goes on to form motor or efferent structures. This patterning occurs due to the production of Sonic the Hedgehog protein. An easy way to remember this is to recall that the video game character, Sonic the Hedgehog, is a runner, so motor plate patterning makes sense. Thank you, science, for an awesome name. Conversely, the alar or dorsal plate is patterned into sensory or afferent with an A structures. This sensory or afferent patterning occurs via the signaling of the bone morphogenic protein. To make patterning stick in your mind, let me show you a cross-section of the spinal cord oriented in the same way as our illustrations here with the same yellow separating line. Looking at the dorsal section of the spinal cord, this area, It was patterned to become the sensory or afferent elements through the signaling of the bone morphogenic protein. As you may know, these structures are called the dorsal horns and contain cell bodies important for afferent or sensory signaling. Additionally, the dorsal columns of the spinal tract, as the name suggests, run in the dorsal aspect of the spinal cord and relay afferent or sensory signals concerning proprioception, pressure, vibration, and fine touch. Looking at the ventral surface of the spinal cord, you can find the anterior or ventral horn cells, which represent the cell bodies of motor neurons. You may know that in ALS and polio, the anterior or ventral horn cells are destroyed, resulting in loss of motor functions. Importantly, the Sonic the Hedgehog protein is responsible for ventral or efferent motor patterning. Overall, the key point to understand is that neurodevelopment and patterning via the bone morphogenic protein and the Sonic the Hedgehog protein signaling results in the dorsal afferent sensory patterning and the ventral efferent motor patterning of the nervous system. Returning to the neurotube, I want to show you how its development progresses. To orient you, the opening in the neurotube gives rise to the ventricles of the brain and the central canal of the spinal cord. As such, that thick rim of blue you see surrounding the inside of the tube can represent ependymal cells, which serve important roles in cerebrospinal fluid handling and line the ventricular and canal spaces. With that orientation, let's pretend that we take a cross-section through this neurotube, represented by the green line, and then we look down on top of that cross-section. We would see that the neurotube produces outpouches with a hollow center, representing the ventricles, of the developing brain structures. These three primary brain vesicles, which are outpouches of the neurotube, go on to form 5 secondary vesicles that give rise to all the structures of the central nervous system. Specifically, the prosencephalon goes on to form the telencephalon, which goes on to form the cerebral hemispheres, basal ganglia, and lateral ventricles. A high yield point is that the Sonic the Hedgehog protein is crucial in signaling the prosencephalon to become the telencephalon. If that Sonic the Hedgehog protein signaling does not occur appropriately, the prosencephalon will not divide into the telencephalon, and a condition with an actually perfect name is produced called holoprosencephaly, represented here with one giant monoventricle. Understanding neuroembryology makes this condition intuitive, doesn't it? Moving along, I want you to think of these vesicles and what they develop into in a logical way. See the telencephalon with the cerebral hemispheres lie on top of the thalamus and hypothalamus, which derive from the diencephalon. Then, the brainstem is, of course, in order as the midbrain emerges from the mesencephalon. From the rhombencephalon, the pons and cerebellum form, specifically from the metencephalon. To remember this, I always ask if the pons and the cerebellum have met each other. Met for metencephalon. And finally, from the rhombencephalon and eventually the myelencephalon comes the medulla, the lowest part of the brainstem. So, as you can see, if you know normal neuroanatomy, the embryological derivatives make sense and vice versa. Now, let's begin talking about neurotube defects. To do this, we need to orient ourselves by looking directly down on the dorsal or posterior aspect of the developing neurotube. If we did this, we would see that the developing neurotube may look like this. Normal neurotube closure looks like this area. As you can see, the tube has closed. The rest of this diagram demonstrates abnormal neurotube defects at the top and bottom. Let me explain. This region is called the anterior or rostral neuropore. Yes, pore. The neurotube before it closes is called more specifically a neuropore. If the rostral or anterior neuropore fails to close into the neurotube, you get a neural tube defect, which can manifest as anencephaly, where the brain and skull do not develop, or encephalocele, which is a cyst-like collection of fluid protruding from the occiput of the baby's head. To help you recall that rostral and anterior are similar terms, use the mnemonic rostro is nostril. Yes, rostral is nostril, as the nostrils or nose is an anterior structure. Moving along, this area is called the caudal or posterior neuropore. If this neuropore fails to envelop into a neural tube, this can lead to forms of spina bifida. Moreover, it turns out that the closing of the neuropore actually proceeds in the cranial to caudal direction, such that the anterior rostral neuropore closes first and the caudal or posterior neuropore closes last. This cranial caudal progression of closure of the neuropore into the neural tube explains why caudal or posterior neuropores are the most common congenital malformation. Stated another way, spina bifida is a more common congenital malformation than anencephaly or encephalocele because of the cranial to caudal progressive closure of the neuropore into the neural tube. Now, let's discuss neural tube defects in more detail. Starting with failure of the rostral or anterior neuropore to form the neural tube. Again, we are talking about this section of the developing neural tube. This can result in anencephaly. An means without, and encephaly means brain. So the brain and skull fail to develop. So here is a picture of a cute baby. Now let's imagine that anencephaly occurred due to failure of the rostral neuropore to become the neural tube. Then the brain and skull would not form, and classically the fetus would be said to have a frog-like appearance, due to the prominence of the eyes without the brain and skull developing that resemble the prominent eyes of a frog. This condition is sadly not compatible with life, and I recommend you do a quick Google search to see exactly what this condition looks like, as the boards will likely show you a picture and then ask you what is the underlying mechanism. The answer is failure of the anterior neuropore to close into the neural tube. To discuss some clinical features, again, the brain fails to develop, and without a properly functioning central nervous system, the fetus cannot cycle the amniotic fluid while in utero, leading to polyhydramnios. Recall that the fetal kidneys produce the fetal urine, and that the fetal urine constitutes the majority of amniotic fluid. Normally, the fetus swallows the amniotic fluid to aid in lung development and to recycle the fluid. Without a central nervous system, a signal for swallowing of the amniotic fluid does not occur, leading to an abnormally increased amount of amniotic fluid, building up a condition called polyhydramnios. As such, anencephaly can be detected on fetal ultrasound, as well as by testing the maternal serum for increased levels of alpha-fetoprotein. With failure of the neuropore to close, alpha-fetoprotein leaks out, crosses the placenta, and can be detected in the maternal serum. With neurotube defects, alpha-fetoprotein levels can be elevated. Additionally, if the amniotic fluid was sampled, an increased level of acetylcholinesterase may be measured in that amniotic fluid for the same exact reasons. It leaks out of the fetus due to the opening of the neuropore. Note the distinction. Alpha-fetoprotein is detectable in the maternal serum. Acetylcholinesterase is detected in the amniotic fluid. Lastly, an encephalocele can form, which is a cystic dilation that classically occurs on the occiput or back of the head, like here. This encephalocele can contain neurotissue as well as result from failure of the anterior neuropore to fuse into the neural tube. Again, go Google search an image of this to make it clearer in your minds. Now we get to discuss the most common congenital neural tube defects, which fall under the term spina bifida. These occur due to failure of the caudal or posterior neuropore to close and form the neural tube. Specifically, this section of the developing neuropore outlined in red. If this section of the neuropore closed correctly, then the vertebral arch would encircle the spinal cord, such as shown in this normal image here. If the caudal or posterior neural pore does not close to form the neural tube, then we get a class of neural tube defects that fall under the heading of spina bifida. Spina stands for spine, and bifida stands for split into two. As you can see, at the tip of this arrow, the posterior vertebral arch failed to close over the top of the spinal cord. This occurred due to failure of the caudal or posterior neural pore to form the neural tube. Specifically, this form is called spina bifida occulta because by visually examining the back of the baby, the posterior vertebral arch defect would be hidden or occulta. What would likely be present is a tuft of hair or a skin dimple. This is very high yield. Make sure you know that spina bifida occulta can present with a tuft of hair and or skin dimple on the lower back. On your pediatric rotations, you will see pediatricians specifically examining this area of the baby to check for this finding. Moreover, and I want you to listen very closely, spina bifida refers to a posterior vertebral arch defect, split spine, remember? Got it. Good. Because there are multiple forms of spina bifida, such as spina bifida with a meningocele, where, as the name suggests, the meninges protrude through the posterior vertebral arch defect, leading to a meningocele or cystic dilation that can be observed via ultrasound or physical examination on the lower back of babies. Additionally, spina bifida can occur with a myelomeningocele. Meningocele refers again to protrusion of the meninges through the posterior vertebral arch defect. The myelo refers to neural tissues, such as the nerves of the cauda equina protruding through the posterior vertebral arch defect as well. As you may have reasoned, spina bifida with a meningocele or myelomeningocele are much more severe lesions than spina bifida occulta. Overall, the diagnosis of these conditions can occur via physical exam, in utero ultrasound, and by measuring the amount of alpha-fetoprotein in the maternal serum. Again, the neural pore fails to close into the neural tube, allowing alpha-fetoprotein to flow out of the fetus, across the placenta, and into the maternal serum where we can measure it. Notably, increased alpha-fetoprotein levels are more commonly observed in the serum of mothers with babies who have spina bifida with a meningocele or myelomeningocele, whereas spina bifida occulta is again occult or hidden and is less likely to have elevated alpha-fetoprotein levels in the maternal serum. Additionally, if the amniotic fluid of the baby was sampled, increased levels of acetylcholinesterase could also be elevated. As you may know, acetylcholine is a very important neurotransmitter in the nervous system. So finding elevated levels of the enzyme involved in acetylcholine metabolism makes sense. Lastly, another condition is called myeloschisis or raschisis, which is the most severe of the neural tube defects. In this condition, the neural pore completely fails to fuse at all, leading to exposed, unfused neural tissue without skin or meningeal coverings. Overall, these are all forms of posterior or caudal neural tube defects. Forms of spina bifida, that is, that can result in lifelong motor, sensory, and autonomic problems for the baby, even after surgical repair. That is why it is so crucial to prevent neural tube defects from occurring, and we can do just that with vitamin B9, folate, as we will now discuss. Remember, student doctors, an ounce of prevention is worth a pound of cure. Preventing neural tube defects starts by supplementing your knowledge about folate or vitamin B9 supplementation. Vitamin B9 or folate is crucial for proper neural tube development. The timing of folate or vitamin B9 supplementation is just as important. The process of neural tube development begins and ends by about the third week 21 days, or 4th week of development. Therefore, neural tube development occurs before many women know they're pregnant. Therefore, it is highly recommended that all reproductive age women supplement folate in their diet. Supplementation must occur before a woman is pregnant or very early in this pregnancy to significantly reduce the chance of neurotube defects developing, because this process, as you can see, can be completed by the 3rd or 4th week of gestation. A mnemonic used to remember this is vitamin B9 for 9 months of pregnancy, as vitamin B9 is folate. Now, you may be wondering exactly why folate is so important for protecting against neurotube defects. Let's explore this more on the next slide. Pictured here is one of the most important biochemical processes that involves folate, vitamin B9 metabolism. That is the synthesis of thymine, which is needed for proper DNA synthesis. With rapidly dividing fetal cells, DNA synthesis is in high demand, and this folate-dependent pathway becomes the difference between having and not having a neural tube defect. Let me walk you through this high-yield biochemistry. Folate, vitamin B9, can be converted into dihydrofolate. Then, dihydrofolate is converted by dihydrofolate reductase into tetrahydrofolate. Tetrahydrofolate is converted into N5-N10 methylene tetrahydrofolate. Now we are ready for the grand finale. Thymidylate synthase takes that N5-N10 methylene tetrahydrofolate serving as a cofactor and DUMP, deoxyuridine monophosphate, serving as a substrate, and produces deoxythymidine monophosphate. Deoxythymidine monophosphate is a crucial pyrimidine for DNA synthesis. DNA synthesis is in high demand in the developing fetus as fetal cells are rapidly dividing. Overall, this biochemical pathway involving folate metabolism demonstrates folate or vitamin B9's crucial role in thymine metabolism, DNA synthesis, and its importance in the proper development of the rapidly dividing cells of the fetus. Therefore, disruptions of the folate metabolism can lead to neurotube defects, as the demand of rapidly dividing fetal cells for DNA cannot be met. This occurs most commonly due to folate deficiency in pregnant women. Additionally, it is high yield to know the drugs that alter folate metabolism and therefore can cause neurotube defects. Perhaps the most famous are the dihydrofolate reductase enzyme inhibitors, methotrexate, trimethoprim, and paramethamine. Methotrexate is commonly used to treat cancers and autoimmune diseases, especially rheumatoid arthritis. Trimethoprim, when combined with sulfamethoxazole, is called Bactrim and is commonly used as an antibiotic. Paramethamine is also used to treat infectious diseases. Importantly, methotrexate is designed to affect human dihydrofolate reductase, while trimethoprim and paramethamine are designed to have higher affinities for microorganisms' dihydrofolate reductase enzyme compared to human dihydrofolate reductase enzymes. Nonetheless, all of these agents can, in some capacity, inhibit human dihydrofolate reductase enzymes and, as such, can predispose infants to neurotube defects. Another class of agents notorious for altering folate metabolism are the anticonvulsants. Anticonvulsant agents such as carbamazepine, phenytoin, and valproic acid, among others, can lead to neurotube defects. In pregnant women who require these agents for seizure control, a high degree of clinical expertise is needed to manage seizures, provide high folate supplementation, and to be mindful of the teratogenic effects of these agents on the developing fetus, as all of them can alter folate metabolism in one way or another and predispose the infant to neurotube defects. Student doctors, make sure you understand this biochemistry. It's not a matter of if you will see folate on your exams, only when and how many questions. Another risk factor through complex metabolic pathways for neural tube defects is maternal diabetes. This is kind of intuitive though, because, as you know, diabetics commonly develop polyneuropathy in a stocking glove pattern. So, by logical extension, it makes sense that diabetes in the mother could interfere with normal neurodevelopment of the fetus. To help you remember this fact, use this image of sugar-filled suckers on the screen. The candy is sugary to remind you of diabetes. The red sucker represents the mama sucker, and the baby suckers and their sticks represent offspring with complete neurotubes. However, this sucker developed a neurotube defect. I hope this little picture helps you remember that maternal diabetes is a risk factor for neurotube defects. Let's cover another high-yield association with neurotube defects. Pictured on the slide is a form of spina bifida, a myelomeningocele. My question to you is, what disease process is highly associated with this type of neurotube defect, that is, a myelomeningocele? The answer is a type 2 Chiari malformation, which is commonly associated with a myelomeningocele. In fact, if a myelomeningocele is found, you must check for Chiari type 2 malformation. Specifically, the myelomeningocele may present with motor and sensory loss at the level of the lesion. Adding on to this, a Chiari type 2 malformation is a congenital defect of the posterior fossa that houses the cerebellum. Due to malformations of the posterior fossa, the cerebellar vermis, cerebellar tonsils, and medulla herniate through the foramen magnum, which is a major opening leading from the skull to the spinal column. Congestion at the foramen magnum can lead to non-communicating hydrocephalus, as the person's own brain tissue is serving as a roadblock, causing hydrocephalus. To help make this clearer, this is a picture of a Chiari type 1 malformation, where the white arrows indicate herniation of the cerebellar tonsils into the foramen magnum. That is type 1. We are talking about a Chiari type 2 malformation. In a Chiari type 2 malformation, the cerebellar tonsils, cerebellar vermis, and medulla herniate through the foramen magnum, a much more severe developmental anomaly than a Chiari type 1 malformation. I will note for completeness that a Chiari type 1 malformation presents with headaches that are classically worsened by cough in adults. Notably, the Chiari type 2 malformation is a much more severe condition, and so consider Chiari type 2 malformations an infantile disease, as they usually present with myelomeningocele and non-communicating hydrocephalus, both of which are detected in the infantile stage. In contrast, Chiari type 1 malformations are not associated with these features and, as I said, usually present with headaches in adults that are worsened by cough. One way that I always like to keep the Chiari malformation straight in my mind is by using this mnemonic. Imagine grabbing the spinal cord and pulling down. By pulling down, you would first herniate the cerebellar tonsils, which is seen in Chiari type 1 malformations. And by touching the spinal cord to pull down, this reminds me that Chiari type 1 malformations are associated with syringomyelia, which is a syrinx or cyst in the spinal cord that is seen classically with Chiari type 1 malformations. Now, if you keep pulling harder and harder on that spinal cord, you would herniate not only the cerebellar tonsils, but also the cerebellar vermis and medulla through the foramen magnum, producing a Chiari type 2 malformation, and possibly, if you kept pulling and pulling on that spinal cord, you would herniate it through the posterior vertebral arch defect, producing a myelomeningocele, which is also associated with a type 2 Chiari malformation. This is just one way I try to keep the disorders straight in my mind and to remember their high-yield associations. Before we end this lecture, let's briefly discuss neurocrest cell derivatives. Recall that as the neural pore folds to form the neural tube, it crests at the top, hence forming neural crest cells. These neural crest cells give rise to many structures in the body. The most high yield to know are as follows. The peripheral nervous system, including the autonomic nervous system, dorsal root ganglia, and Schwann cells, which produce the myelin for peripheral nerves. Additionally, neural crest cells give rise to melanocytes, which lie at the basal layer of skin to produce skin pigments, and the adrenal medulla. Medulla. Got it? Not cortex. Adrenal what? Medulla. Let me show you some of these high-yield associations. Again, neural crest cells give rise to what? The adrenal medulla, which you can think of as just one big old nerve sitting on top of the kidney, as it plays a major role in producing epinephrine and norepinephrine. Additionally, neural crest cells give rise to the peripheral nervous system, which includes the autonomic nervous system, which includes the enteric nervous system. Essentially, all the nerves in the gut are from neural crest cells, which form the enteric or GI tract nervous system. In this image is a specific disease called Hirschsprung's disease, where neural crest cells fail to migrate from rostral or the anterior portion of the body to the caudal or posterior aspect of the body, that is, in the colon. Recall from an earlier slide that the neuropore in neural tube develops cranially to caudally. So, those neural crest cells produced from this cranial to caudal neural tube development must then travel cranial to caudal to innervate peripheral nervous system structures, like the colon. In Hirschsprung's disease, these neural crest cells fail to migrate. That's a pretty long journey. So, the colon remains constricted, as no nerves are present to allow relaxation of the colonic wall and progression of feces for defecation. Lastly, another high-yield concept to understand is that melanomas form from melanocytes. Melanocytes are of neural crest cell origin. So, test makers on step 1 love this question. Of showing you an image like this, having you apply the ABCDEs of melanoma, that is, that the lesion is A for asymmetric, B for border irregularities, C for color variation, D for diameter greater than 6 millimeters, and E for evolving over time. Once you make the diagnosis of melanoma, test makers will then ask you, what is the embryological derivative of the abnormally proliferating cell? And you, the astute student doctor, will confidently select that melanocytes are neural crest cell derivatives. Time for a flash quiz. The question reads that a 25-year-old pregnant woman is undergoing prenatal screenings. Maternal serum reveals an increased level of alpha-fetoprotein. Ultrasound of the caudal aspect of the fetus demonstrates a protrusion, consistent with myelomeningocele. The vitamin deficiency most commonly associated with this disorder can present with which of the following? A. Increased homocysteine levels, megaloblastic anemia. B. Increased homocysteine levels, microcytic anemia. C. Increased methylmalonic acid levels, megaloblastic anemia. D. Increased methylmalonic acid levels, microcytic anemia. The correct answer is A. Increased homocysteine levels and a megaloblastic anemia, which is pictured on the bottom of this slide with the classic hypersegmented nuclei of a neutrophil with a background of macrocytes or megaloblastic red blood cells. This is a hard question, friends, especially for this lecture, but this is so Step 1 classic that I couldn't help myself but to include it. The boards tie across so many organ systems and disciplines, so I want to get you ready for test day. In this question, you must realize that folate, vitamin B9 deficiency is associated with neurotube defects. Here, the question lists a form of spina bifida, a myelomeningocele. If you got that, awesome job applying materials from this lecture. The boards then take it one step further and ask you what else folate, vitamin B9 deficiency, is associated with. The correct answer to that is that it is associated with increased homocysteine levels and a resultant megaloblastic anemia, as folate deficiency, as we saw earlier, impairs normal DNA synthesis. Without normal DNA synthesis, the cytoplasm of cells develops, but the nucleus cannot progress to divide, as DNA synthesis is inhibited, producing large cells and neutrophils with larger nuclei. That is, hypersegmented nuclei. As you may know, a megaloblastic anemia can also occur in association with vitamin B12 deficiency, but there, methylmalonic acid and homocysteine levels would be increased, versus with a B9 deficiency, only homocysteine levels are increased. Friends, this was a hard question, but a fair question for the boards, and I hope it helps better prepare you for test day. Win the day, friends, by learning and growing as much as you can each day. We can all do this together. Thanks for watching my lectures and learning with me. It means a lot. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Know that neural tube development relies on bone morphogenic protein, which is in the TGF-beta family of signaling molecules for dorsal patterning of afferent sensory structures. In contrast, the Sonic the Hedgehog protein directs ventral patterning of efferent motor structures. Just remember that Sonic the Hedgehog is a video game character known for running, hence motor patterning of the neural tube. Additionally, know that the Sonic the Hedgehog protein is important for signaling the prosencephalon to become the telencephalon, in that Sonic the Hedgehog protein signaling abnormalities are associated with holoprosencephaly. Next, know that failure of the rostral or anterior neural port to close results in neurotube defect, specifically anencephaly and encephalocele. Additionally, know that the failure of the caudal or posterior neural port to close leads to neurotube defects, which manifest mainly as forms of spina bifida, ranging in severity from the more mild spina bifida occulta to the most severe myeloschisis. Notably, forms of spina bifida, even after surgical repair, can leave a patient with loss of motor and sensory functions at and below the lesion, sadly for life. Therefore, we must prevent neurotube defects if we can with folate supplementation. As such, it is important to know that disruptions in folic acid, vitamin B9 metabolism, maternal diabetes, and Chiari type 2 malformations are associated with neurotube defects. Lastly, know that the neural crest cells give rise to peripheral nervous system structures, the adrenal what? Medulla, you got it, melanocytes, among other structures, and that failure of the neural crest cells to migrate to the distal colon results in Hirschsprung's disease. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always remember, there is a great big beautiful tomorrow.